Today's talk is the first of several planned talks about basic surgical critical care. We'll start off by defining shock, and then we'll spend most of our time specifically talking about septic shock and multi-organ dysfunction syndrome. Shock can be defined as insufficient oxygen delivery or insufficient oxygen utilization to sustain aerobic metabolism. There are many different etiologies of shock. On a surgical service, hypovolemic shock is by far the most common. But we certainly see cases of septic shock, cardiogenic shock, and neurogenic shock as well. What all these different etiologies have in common is their final common pathway leads to the development of acidosis and decreased ATP production. Importantly, shock is not defined by a vital sign like blood pressure. Perhaps shock can be best thought of as a failure of vital organ perfusion. We need to quickly review some basic medical school biochemistry. In the cell cytoplasm, glucose is converted into two pyruvate molecules through a process called glycolysis. This results in the generation of two ATP molecules. If there's sufficient oxygen present, pyruvate then enters the Krebs cycle and the electron transport chain, which are located in the mitochondria. This entire process is called oxidative phosphorylation. The net result, and the important result, is that a single glucose molecule yields 38 ATP molecules, 2 from glycolysis and 36 from the electron transport chain. These ATP molecules are critically important to the cell's function, since cellular energy results from the hydrolysis of ATP into ADP and a proton. Now, aerobic metabolism is a net neutral from an acid-base standpoint, since the process of oxidative phosphorylation reclaims the proton when it generates new ATP. If there is insufficient oxygen available, pyruvate is unable to cross the mitochondrial membrane and enter the electron transport chain. This means that the cell loses out on the 36 ATP molecules that the Krebs cycle would have generated. The net result is that only 2 ATPs per glucose molecule are generated during anaerobic metabolism. This has two important consequences for a cell. The first is that all energy-dependent cellular processes are greatly diminished. The second important consequence is the development of acidosis. In shock, ATP hydrolysis is the source of protons, and it's the inefficient ATP regeneration that occurs during anaerobic metabolism that leads to proton accumulation and clinical acidosis. To counteract this proton accumulation, in the cytoplasm, pyruvate is converted to lactate. Lactate's able to buffer protons, in turn becoming lactic acid. We're able to measure lactate production, and we use it as a marker of the degree of shock that's present. In effect, it's a marker of anaerobic metabolism. But it's important to note that lactate or lactic acid isn't the particular problem. This is just something that we can measure. It's proton accumulation from anaerobic metabolism that is the issue. Now, acidosis critically affects cellular biochemistry, and that's why it's such a severe problem. If a patient has a pH less than 7.2, then enzyme systems stop working well, and hormones like catecholamines don't function either. A pH below 7.0 for any degree of time is incompatible with life. Now that we have a working definition of shock, namely decreased energy production and acidosis, I would like to spend the rest of our time discussing sepsis and its more serious counterpart, septic shock. Before getting into sepsis, I want to briefly mention the Systemic Inflammatory Response Syndrome, or SIRS. SIRS and sepsis are clinically indistinguishable from each other. SIRS, however, is caused by severe tissue injury, and sepsis is caused by an overwhelming infection. Both syndromes can result in multi-organ dysfunction syndrome and even death. The bottom line is that the body responds to injury and infection in the exact same way because the same cytokine cascade is initiated in both conditions. If this is a subject that interests you, I have a YouTube video out there called The Systemic Response to Injury that goes over all of this in much more detail. I've copied here the most recent definitions of both sepsis and septic shock. Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. This infection can be documented or merely suspected. The degree of organ dysfunction is measured by the SOFA score, which we'll go over in just a bit. The hospital mortality rate for a septic patient is above 10%. Assuming adequate fluid resuscitation, septic shock requires vasopressors to maintain a mean arterial pressure greater than 65 millimeters of mercury, and the definition also requires an elevated serum lactate as well. As you might gather, the hospital mortality rate for a septic shock patient is much higher, and it's as high as at least 40%. In response to a pathogen, the cells of the innate immune system secrete cytokines into the local environment. These cytokines are responsible for initiating and perpetuating the host's inflammatory response. Ideally, there is a balance between pro-inflammatory and anti-inflammatory cytokines. But if the pro-inflammatory cytokines overwhelm the anti-inflammatory cytokines, then we get a systemic response that we know as sepsis. The hallmarks of sepsis include fever, although some patients can be hypothermic. Most patients with sepsis have an elevated white blood cell count, although a few are actually leukopenic. The hemodynamic profile of a septic patient consists of an increased cardiac output and a decreased peripheral vascular resistance. This is a very different picture than we would see in someone with hypovolemic shock or cardiogenic shock. In those cases, the cardiac output would be low and the peripheral vascular resistance would be very high. Most septic patients are hyperglycemic, and most have some degree of organ dysfunction as well. I've listed here some of the patient risk factors for developing sepsis. It's probably fairly intuitive that older patients or immunosuppressed patients or patients with systemic illnesses like diabetes, obesity, and malignancy have by far the highest risk for this condition. There isn't a single specific test for diagnosing sepsis. The clinical presentation is probably the most important evidence, with lab tests, x-rays, measured physiologic parameters, and culture results as important supportive evidence. Most patients with sepsis have some degree of fever, tachycardia, and hypotension. Early on, the patient's skin may be warm and well perfused. This is because in early sepsis, cardiac output tends to be elevated and peripheral vascular resistance tends to be low. As the syndrome progresses, however, cardiac output declines and peripheral vascular resistance increases, so the patients become cold and clammy, just like a patient in hypovolemic shock. There's often evidence of organ dysfunction as one of the presenting signs. On a surgical service, declining urine output and a rising BUN and creatinine in spite of adequate fluid resuscitation would always be concerning for early sepsis. Increased oxygen requirements and increased PEEP requirements are also concerning, and in elderly patients especially, altered mental status is often the earliest warning sign for the development of sepsis. As far as lab tests go, many provide supportive evidence, but no single test is diagnostic of sepsis. The CBC is extremely valuable and provides information on the white blood cell count as well as the platelet count. In sepsis, many patients have a platelet count that drops below 100,000. A basic chemistry panel provides more useful information, in particular about the BUN and creatinine. Liver function tests and coagulation studies like the prothrombin time provide evidence of hepatic dysfunction. A blood gas analysis provides evidence for the degree of acidosis as well as the status of the respiratory system. The typical patient with sepsis is hypoxic and hypocarbic. The decreased CO2 is generally in response to the acidosis. Lactate is a very useful study, and it's used to follow the therapeutic response because it's a marker for anaerobic metabolism. As patients improve, the lactate level drops because they're starting to switch back over to aerobic metabolism. All patients who are suspected to have sepsis should have blood cultures drawn, ideally before antibiotics have been started. If the patient has a central line in place, then cultures should be drawn through this line as well as from a peripheral site. If the patient is immunosuppressed or has been on long-term antibiotics, then fungal cultures should be requested as well. Urine, sputum, and wound cultures should be obtained if clinically indicated. And interestingly, in over 50% of cases, no organism is ever identified in a septic patient. And so a positive culture result is not necessary to treat a patient for sepsis. Imaging is valuable in looking for the source of the sepsis. Probably every septic patient should have a chest X-ray, since pneumonia is so common, both in the community setting and in the hospital setting. On the surgical service, if the patient has had abdominal surgery, then a CT of the abdomen and pelvis becomes the go-to study. This study will allow us to identify drainable fluid collections that may be abscesses, and we can also identify anastomotic leaks this way as well. I've reprinted the Sequential Organ Failure Assessment scoring system here. The organ systems to be checked include the respiratory system, the hepatic system, the cardiovascular system, the coagulation system, as well as the CNS and kidneys. The degree of organ dysfunction present is scored on a 0 to 4 scale for each different organ system. The most recent guidelines for diagnosing sepsis, the Sepsis-3 guidelines, require 2 or more SOFA points to support the diagnosis of sepsis. We'll go over this chart in much more detail in a few minutes when we discuss multi-organ failure. The Surviving Sepsis campaign is a global initiative to reduce the morbidity and mortality from sepsis. This campaign outlines several bundles to be completed within 3 hours and 6 hours. The basic idea is that the septic patient should be identified early, and that this will require a high index of suspicion. Once a patient is suspected to be septic, then there are protocols to begin early and vigorous IV fluid resuscitation and to start antibiotics early as well. Next, source control will be key, and this should be done as quickly as possible as well. The tasks listed on this slide should be completed within the first 3 hours of admission, but ideally they should be completed within the first 1 hour. All patients need a lactate level measured, and all patients require blood cultures before starting any antibiotics. Once blood cultures have been obtained, then broad-spectrum antibiotics should be started. If the patient is hypotensive or has a lactate greater than 4, then vigorous fluid resuscitation is carried out using an isotonic fluid like lactated ringers or normal saline, and the rate is a very aggressive 30 mL per kilogram. The tasks listed on this slide should be completed within 6 hours of presentation. If the patient remains hypotensive in spite of vigorous fluid resuscitation, then vasopressors should be started. The goal is to maintain a mean arterial pressure of at least 65 millimeters of mercury. Norepinephrine is the typical drug used here. If the patient is persistently hypotensive, it's also recommended that a central venous pressure be measured and a central venous oxygen saturation level be obtained as well. If the patient's initial lactate measurement was high, then lactate can be followed as a marker of resuscitation. The endpoints for all this early resuscitation should be a CVP of at least 8 millimeters of mercury, a central venous oxygen saturation of 70% or so, and normalization of the lactate level. I'll provide a little bit more detail about what should happen within the first hour or two of a septic patient's presentation. A septic patient is obviously a very sick patient, and initial attention must be paid to assessing their airway, breathing, and circulation. Many septic patients are going to require early mechanical ventilation. The ventilator should be set to a low tidal volume, and high peak pressure should be avoided. The goal, of course, is to avoid barotrauma. Most septic patients will also need a central line. This will greatly facilitate fluid resuscitation as well as the use of pressor agents. If so desired, the central line will also allow measurement of parameters like CVP and central venous oxyhemoglobin saturation. We've already mentioned the initial fluid resuscitation protocol for a septic patient. These patients get 30 mL per kilogram over the course of 3 hours. The fluid should be an isotonic fluid like normal saline or lactated ringers. However, you're not limited to this amount of fluid, and additional boluses can be given as clinically necessary. Blood should certainly be used for any patient with a hemoglobin less than 7. There are multiple different endpoints for a successful resuscitation. Some of the common ones are a mean arterial pressure greater than 65 millimeters of mercury, a urine output greater than a half a cc per kilogram per hour in an adult, a normal lactate level, and a CVP between 8 to 12, and a central venous oxygen saturation of 70%. Antibiotics should be started within the first hour or two of presentation. The initial antibiotic regimen should be broad spectrum, and we should consider adding fungal coverage if the patient is known to be immunosuppressed or if they're already on broad spectrum antibiotics. Once we have our culture results back, we then want to pare back our antibiotic coverage so we're only covering the known bugs. If the septic hypotensive patient does not respond to fluid resuscitation, then a vasopressor should be started. Norepinephrine is the initial drug of choice, but it is important to remember that septic patients may be catecholamine resistant. If that's the case, then vasopressin should be added to the regimen. On occasion, the septic patient may also need inotropic support, in which case dobutamine or milrinone are good choices. Once the resuscitation efforts are underway, our attention must be quickly turned to source control. In the surgical population, antibiotics alone will rarely be sufficient treatment for sepsis, and so we need to spend considerable effort to look for the source. Cutaneous abscesses like perirectal abscesses can cause sepsis in a poorly controlled diabetic. If a patient has a central line in place, and this is the likely culprit, then the line will need to be removed and the tip cultured. Some patients will present with Fournier's gangrene or gas gangrene of the extremity, and they'll need a radical debridement or potentially even an amputation. ERCPs are invaluable for patients who have cholangitis from an impacted common bile duct stone. And some patients will need a laparotomy because they have ischemic bowel or potentially an intra-abdominal abscess. Glucose control is an important part of the management of septic patients, since insulin resistance and hyperglycemia are common. The goal is to keep the glucose level between 140 and 180 milligrams per deciliter. At this level of control, we minimize infectious complications, but as importantly, we minimize the complications from hypoglycemia as well. How best to manage the insulin is unclear. Patients who have diabetic ketoacidosis are often started on an insulin drip. As the glucose comes down to more normal levels, then they can be switched over to a more traditional insulin sliding scale. The role of corticosteroids in refractory sepsis is very controversial. There have been innumerable clinical trials to study the use of steroids in septic patients, and these studies have yielded conflicting results, and so there's just no consensus on their use. There's a logical reason for wanting to use steroids in a septic patient, and that reason is that septic patients often have adrenal insufficiency. And we well know that an injured or sick patient must be able to mount an adequate adrenal response. And so some ICUs will use hydrocortisone, usually 200 milligrams in divided doses, as a last-ditch sort of heroic effort to deal with the patient who has refractory hypotension, who has not responded to fluids, pressors, or even source control. A major active area of sepsis research is immune modulation, since the septic response can be seen as a problem of too much of a good thing. And so the goal is to find a drug that will downregulate an overzealous immune response. So far, at least, it's safe to say that nothing has worked. There have been numerous clinical trials that have studied the roles of anti-endotoxin antibodies, anti-cytokine antibodies, cytokine receptor antagonists, etc., etc. And so far, at least, there is no FDA-approved drug that will downregulate the overactive immune response that we see in the septic patient. If the septic patient isn't treated early or doesn't respond to antibiotics and source control, the inevitable result is multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome, or MODS, is the most common cause of death in surgical ICUs. And MODS represents the final common pathway from both SIRS and sepsis. At the microscopic level, MODS looks like microvascular thrombosis, which ultimately results in end organ ischemia. The actual reason for this microvascular thrombosis, however, is unclear. It's not certain if this is a problem with oxygen delivery, or whether it's a direct mitochondrial injury, or whether there's some dysfunction in oxidative phosphorylation. Multiple organ dysfunction syndrome can present as a spectrum of disease. Some patients will have a mild and reversible course, but most others will progress to complete organ failure. In general, this syndrome begins 24 to 48 hours after the original insult. The lungs, the liver, and the kidneys are usually affected first, with the cardiovascular system, brain, and bone marrow affected last. Acute lung injury in MODS is manifested by hypoxemia. To further stratify the degree of lung injury, the arterial oxygen pressure can be divided by the fraction of inspired oxygen that the patient is receiving. If this ratio is less than 100, then this patient has the most severe form of acute lung injury, which we call ARDS, or acute respiratory distress syndrome. The management goals in acute lung injury are to keep the oxygen saturations above 92% while minimizing barotrauma and oxygen toxicity. We minimize barotrauma by using a low tidal volume setting on the ventilator and keeping airway pressures below 30. We minimize oxygen toxicity by making liberal use of PEEP. PEEP keeps the alveoli open and small airways open, and this improves oxygenation. Overall, this allows us to use a lower concentration of oxygen. The degree of acute kidney injury present is stratified by the urine output and creatinine. A creatinine level greater than or equal to 5, or a urine output less than 200 mLs per day represents the highest degree of kidney injury in multiple organ dysfunction syndrome. This is also associated with a very high mortality rate. The first priority in managing acute kidney injury is maintaining renal perfusion. This is accomplished by optimizing the patient's volume status, as well as by optimizing their blood pressure and cardiac output. All nephrotoxic drugs should be avoided, and other important drugs should be renally dosed if possible. Patients with the most severe degree of kidney injury will likely need renal replacement therapy. This would most commonly be delivered by hemodialysis. The degree of acute liver injury is stratified by the serum bilirubin concentration. where the total bili greater than or equal to 12 corresponds to the highest degree of injury. The etiology of acute liver injury in sepsis is hypoperfusion and splanchnic vasoconstriction. Shock liver is a type of hypoperfusion injury where the patient initially presents with greatly elevated transaminases, which represents cell necrosis. The elevated total bilirubin generally follows within the next day or two. Hepatic synthetic dysfunction is a very late finding and an ominous finding. The first manifestation of synthetic dysfunction is usually a rising INR. Hypoglycemia would be a terminal finding. The management of acute liver injury revolves around maintaining perfusion as well as avoiding hepatotoxic drugs. Additional important goals include maintaining adequate calories and managing any encephalopathy that might be present. Acute cardiovascular dysfunction in MODS is stratified by the mean arterial pressure and the need for increasing doses of vasopressors to keep the MAP at an acceptable level. There's also a small group of patients who may need an inotrope as well. The management of acute cardiovascular dysfunction begins with aggressive fluid resuscitation. If fluids alone are unable to keep the MAP above 65 millimeters of mercury, then vasopressors are added. The typical drug chosen first is norepinephrine. But if norepinephrine alone cannot keep the MAP at an acceptable level, then vasopressors should be added. The use of invasive monitoring devices like pulmonary artery catheters to help guide fluid and pressor therapy has never been shown to improve clinical outcomes, so they are not part of most surgical ICU protocols. Bedside echocardiograms may provide the information that we are looking for in a less invasive way. The degree of CNS dysfunction present in MODS is measured by the Glasgow Coma Scale. The CNS abnormalities present may range from confusion to delirium to frank coma. The amount of CNS dysfunction to attribute to MODS can be difficult to ascertain, however, because the CNS is also affected by a history of pre-existing dementia, pain, a history of substance abuse, the altered sleep-wake cycles that exist in the ICU, and of course, other medications that the patient may be taking. Patients with altered mental status plus MODS are extremely challenging to take care of. A bedside sitter, ideally a family member, is valuable to help orient the patient. Restraints should be avoided if possible, but they are often necessary to prevent the patient from harming themselves or pulling out important lines and tubes. If medicines become necessary, then Haldol is typically the drug of choice. This drug has minimal cardiovascular side effects. Benzodiazepines like Valium and Ativan should be avoided at all costs. The septic patient benefits from early enteral nutrition just like any other injured patient. Now, whether these patients benefit from immune-enhanced formulas is controversial and of unproven benefit. Nevertheless, many surgical intensivists do give their sick and injured patients nutritional formulas that have increased amounts of arginine, glutamine, omega-3 fatty acids, and antioxidants like vitamin C, zinc, and selenium. Here is my list of references that I used to put together this talk. The URL for this course's website is shown here, as well as a few links to some of my other talks on basic surgical care. Thanks again for your attention.